We're not ready yet. Please excuse us. We'll probably begin in about 5 minutes. I understand it's already 1. All right, if everyone could just settle down. Okay. Agenda item number 6, attachment number 16.89. Request to establish a new HCPCS Level 2 code to identify X10 pressure modulated knee rehabilitation system. There are no speakers for this item. Are there any questions or comments? Okay, moving right along. Agenda item number 7, attachment 16.90. Request to establish a new Level 2 HCPCS code to identify the Philips Respironics Wisp full face convertible mask. Primary speaker is Dr. David White.
Thank you. Good afternoon, and I will be brief. What I want to talk about is establishing a new Level 2 HCPCS code for a mask that's a convertible mask, which means it can be served as both a full face mask and or a nasal mask, depending on the need of the patient, to deliver positive airway pressure. So we believe that a new, unique HCPCS code for a convertible mask is warranted, justifying reconsideration of the preliminary decision to use the code A7034. That's a code for a nasal mask alone, not a nasal and a full face mask. And we say this for 3 reasons that I'm going to expound on a little bit. First, the existing coding system does not support a convertible interface. Number 2, a convertible interface may increase patient compliance or adherence, we believe. And thirdly, overall, a convertible interface has the potential to save Medicare program and beneficiaries money. And let me back up. I should have introduced myself. And I'm David White. I'm a professor of medicine at the Harvard Medical School. I'm a standing consultant also to Philips Respironics and have been for a while. Sorry about that. Just to make sure everybody's on the same page regarding sleep apnea, here's a sagittal section through the upper airway. Most of us breathe through our nose. Air passes behind the tongue, the uvula, and the soft palate, and this area is unobstructed to breathing. In certain individuals, when they go to sleep, the muscles in the airway relax, the tongue, palate fall posteriorly, and when they completely obstruct the airway, you have an apnea. When they largely but not completely obstruct the airway, you have what we call a hypopnea. And these cause two problems for afflicted individuals. One is if you're breathing intermittently, your oxygen level is going up and down, and oxygen levels going up and down activates a lot of systems in the body about which there's considerable evolving literature suggesting the development of cerebrovascular and cardiovascular disease. The other problem these patients have is that to resume breathing following an apnea or hypopnea, you generally have to wake up. Not that they're commonly aware of it, but you transiently wake up, take 3 or 4 breaths, then go back to sleep, and your sleep becomes sufficiently fragmented that you're quite sleepy and your quality of life goes down. So it's a disorder with some important adverse consequences for the people. It's also a very common disease. Among middle-aged adults, 10 to 17% of men and 3 to 9% of women suffer from symptomatic sleep apnea, so very common. And particularly relevant to this group, the prevalence of sleep apnea increases with age, with adults over 65 having the highest prevalence of any group examined. And the standard treatment for sleep apnea is positive airway pressure, or PAP or CPAP, devices while sleeping. And all evidence indicates that PAP devices work superbly well. The problem with PAP is adherence. You've got to get people to wear it and wear it very regularly. So compliance with it relies on the patient use for as much of the sleeping duration as possible. And patients face challenges in adhering to therapy. Current evidence suggests that only about at least 25% of patients discontinue use within the first year. Only 30% of patients use the device consistently for an average of 6 hours per night, and about 50% of patients use the device only for an average of 3.5 hours per night. And clearly the data suggests that using it 6 to 7 hours per night is needed to get maximum benefit. Now, what does this have to do with masks? Well, there are currently 3 types of masks that are available. There's a full face mask that goes over both the nose and the mouth. There's a nasal mask that just goes over the nose. And they're what they call nasal pillows that just sit on the end of the nose and don't formally have a mask at all. It just seals at the nose. And patients are generally assigned a mask type at the sleep clinic. So they go home with one mask in their hand and the CPAP device. Initial mask determination, however, may not prove to be appropriate for long-term use or after patient circumstances change, and I'll outline that in a minute. So we believe access to multiple mask type options may increase the number of patients that adhere to positive airway pressure and increase the amount of time patients use their device each night as patients do change masks over time. And it's very clear that over time, people move from a nasal to a full and back and forth with some regularity. Now here's a picture just demonstrating the mask, and it's got 2 configurations. As I said, one is a full face mask, looks like this, goes over the nose and the mask. It can be pulled off with the headgear intact, the tubing intact and everything, and converted to a nasal mask, such that the patient on any given night can use whichever of these they want to by simply pulling the straps off and attaching the new interface. So a convertible mask allows the patient to easily switch between a full face mask and a nasal mask without the program or patient needing to purchase a second mask. And reasons for switching cushion type due to changing circumstances include, but is not limited to, skin breakdown. Pressure on the face can cause skin breakdown, and the footprint of the mask is quite different. And so if you're getting skin breakdown in one area, you can switch to the other mask and avoid it. Mask discomfort. Sometimes the masks are just uncomfortable, and a different mask is better. Claustrophobia. The full face mask makes some people quite claustrophobic sometimes, and they need to switch to a nasal mask. And then temporary or chronic nasal congestion. If you can't breathe through your nose, you can't use a nasal mask, and you would at least temporarily need to move to a full face mask. And we know from a lot of data now, actually, that skipping CPAP or PAP for even one night leads to a return of the sleep disordered breathing and daytime sleepiness, undermining the likelihood of ongoing compliance. And again, compliance is the issue. We've got to get people to use these things, and the more comfortable you can make them in doing so, the more likely you are to get adherence. So, what are the coding barriers that exist? Right now, there are 2 codes. There's the A7034 for a nasal mask, which this device, this convertible mask, has been assigned, and there's A7030 for a full face mask. There's no appropriate existing code that clearly includes convertible masks. Current coding options therefore create what we believe to be counterproductive barriers to access to care. If billed as a nasal mask, which you have to do if you want to get this device right now, patients cannot get replacement full face mask cushions without a new prescription. It's actually a two-step process they have to go through with the DME to get to a full face mask, which is going to produce substantial delay. If billed as a full face mask, patients cannot get replacement nasal cushions without a new prescription. So it has to go back and forth, and it adds complexity and difficulty for both the patient and the physician to accomplish this, and may add cost if you have to go to a completely new mask. The HCPCS preliminary decision, as I said, the preliminary decision assigns the convertible mask to the A7034, the nasal mask. Therefore, patients prescribed this mask and thus initially require a full face cushion would not be able to get a replacement full face cushion under the original requested A7034. They can only get nasal supplies because they're believed to be a nasal mask. The program will see this patient only as a nasal mask patient, not eligible for full face mask replacement cushions. The proposed solution is, as we believe, to be a new code for the convertible mask. So we request a new HCPCS codes for a convertible interface used with a positive airway pressure device. The new code could be used in conjunction with new or existing codes for replacement cushions, and the numbers are listed there. And the replacement schedule could be refined by the Medicare DMEs as they saw fit. And we believe this can reduce the frequency of purchasing complete replacement masks where only a change in cushion is needed. Again, the difference between all of this plus tubing and whatnot, as opposed to just this, which should be considerably less expensive. So I'll summarize. We believe there is no clear or appropriate place for a convertible mask in the current coding system. The solution, we believe, creates an efficient mechanism for patients to switch between mask types, potentially improving patient compliance with PAP therapy. It removes administrators' barriers to replacement cushions created by the existing system, which again is problematic for both patients and the doctors taking care of those patients, and it doesn't allow for quick changes in masks as needed. And we believe it can be used to promote greater efficacy and cost effectiveness under Medicare. Thank you. We have no 5-minute speakers, so if anyone has any questions, I'd be delighted to try to answer them.
Thank you, Dr. White. Can you please explain one more time the hardship that a patient would go through if they were assigned one mask initially and then want to switch or also in addition get the other interface?
Well, if let's just say, to get this convertible mask now, you'd have to have a nasal mask prescription. So the DME has a nasal mask prescription for the person. If they're using it sometimes as a full face mask and need a new full face cushion replacement over time, which they all do, the replacements occur something like every 3 to 6 months, they would not be able to get that without the doctor first switching them over with the DME to a full face mask and then prescribing a prescription for a full face mask. So it's a two-step process they have to do with the DME to get access to the full face mask. And if they're using the full face mask and they want to be able to access to the nasal cushion, they then have to get another prescription because the DME has them listed as a full face mask user. Supplies for a nasal mask they're not eligible for, so they have to get a new prescription. And if you ever think about CPAP, at least in my mind, people not using CPAP for periods of time is the problem. And if I need a prescription for a full face mask cushion and I can't get it, or I can't get it quickly, and then I got to take it to the DME and weeks go by, it hinders ongoing adherence with a product where adherence is the great barrier to successful therapy. Am I clear?
You're clear, thank you. So you don't have any actual information about compliance changes right now, do you? Because you said May in your slide.
There's not been a study, a formal study. Clearly we know that masks can influence. If you let a patient choose their own which mask they want, they do better than if you just give them a mask. That's known. We also know that patients do change masks over time. There has not been a study that has compared giving them 2 masks versus giving them 1 mask and looking at what happens to adherence over time. There just hadn't been a study of that to date. Thank you.
Agenda item number 8, Attachment number 16.91, request to establish 2 new Level 2 HCPCS codes to identify the 2 components of the Swallow Strong system. Primary speaker is Mr. Eric Horler.
Not the correct slides. There we go. Good afternoon. I'm Eric Horler. I'm the president and CEO of Swallow Solutions. I'm relatively new to Swallow Solutions. The company's been around for about 7 years. Swallow Solutions is the manufacturer of the Swallow Strong device. I want to thank the HCPCS work group for giving us the opportunity to come in today and present some new information that's relevant to our application for HCPCS code for the Swallow Strong device. There we go. So on the right-hand side of this slide, you'll see the topics that I want to cover during this presentation. The first thing I'd like to do is I would like to explain the difference between our current application and the previous applications, and why we believe that you should give fair and fresh view to our current application. After that, I will talk about the disease state that we are dealing with here, the therapy that's provided by our product, and then, of course, the product in detail. I'm going to, at that point, present some new information around where and how the product is used, specifically that in the grand majority of cases it's being used in the home, independently by the patient or maybe with a caregiver, and not in an office or in the direct presence of the clinician. I will take this advantage, or take advantage of this opportunity also to present some new clinical evidence that's been published since our application was submitted. And then finally, we'll discuss or explain why we disagree with the preliminary decision that the device and the transducer accessory are part of a service, and rather why we feel that the device and its accessory are better described as durable medical equipment. And I will reference another oral therapy device that we found that's used in a very similar use setting and in a very similar sort of use scenario that does have existing HCPCS codes. We use that as our precedent or our model for our recommended wording for these codes. So, as mentioned, I would like to touch upon the number of applications that have been submitted either by or on behalf of Swallow Solutions. This is our 6th application. If you go back in time, on the left-hand side here, you can see kind of a timeline of the evolution of Swallow Solutions and where each of those applications fell. The first 3 applications were actually submitted before the company even had a product and before it even had FDA registration for that product. The 4th application was submitted very soon after the first product launched, before there was very much market experience and not much knowledge over how that product was actually going to be used. I understand that the person who was submitting these applications on behalf of the company believed this was the way to get on the radar of CMS. Perhaps requesting a meeting might have been another approach, but this is what did end up happening. Unfortunately, at that point in time, they had more a concept of a product than actual knowledge of a product and its use. And as a result, you have multiple applications that have some confusing, conflicting, and bluntly some misleading information in them. We've tried very hard in our last application to really clear that up and to explain in better, more clear terms exactly how, why, and when the product is used. On the right-hand slide here, you can see some of the specific things that have not been consistent across our applications. So one thing was that when the first applications came out, it was a different product. The first product that was launched was called the Madison Oral Strengthening Therapeutic. It delivers exactly the same clinical therapy, but it was only from having that product in the market that we learned that this was not going to be used in a clinician's office. It was not used as a diagnostic, that it was going to be used solely as a therapeutic, and it was really going to be used in an in-home application. The company completely redesigned the product at that point, optimizing it around in-home use. And I'm going to talk about that in another slide. The newer product then launched, which is the Swallow Strong system. This is the product that we're specifically describing in our current application. So having led with that, let me talk a little bit about the disease state that we're treating and the therapy that the product delivers. Dysphagia is the clinical term for a swallowing disorder. Essentially, this is where a bolus of food or liquid, instead of being directed into the digestive system, gets directed into the pulmonary system. You end up with a condition that's known as aspiration. Just think about getting food or liquid down the wrong pipe, in colloquial terms. Left untreated, this leads to a number of complications, but the most common is pneumonia. People with dysphagia find themselves repeatedly hospitalized for pneumonia, or what's sometimes referred to as aspiration pneumonia. One study estimated that the average cost per episode is about $17,000 to the healthcare system to treat a case of aspiration pneumonia. Most of these patients are geriatric. 15%, one published study reports that about 15% of people over the age of 65 have dysphagia. 64% of people who've had a stroke have signs or symptoms of dysphagia following their stroke. So it gives you a general idea of who the patient population is. We work very closely with the National Foundation on Swallowing Disorders, which is the patient support group for dysphagia, and they are very much aligned with us in believing that this is a major, significant need out there, and that patients need access to new treatment modalities that are more effective and more evidence-based than what's available today. The therapy that is delivered by our product is known as oropharyngeal strengthening. So it's for patients with dysphagia who meet a specific defined criteria. And that's an important point. That criteria was spelled out in our written application. There was an inverted pyramid that sort of shows what all those criteria are. So we're not saying this is a therapy for everyone with dysphagia. And in fact, a patient who's going to be treated for this needs to have this therapy prescribed by a physician and then administered by a licensed speech pathologist. And the role of those clinicians in this care is extremely important. They will determine whether the patient does meet the criteria. If the patient meets the criteria, then in most cases, that patient would go purchase the transducer, rent the device, work with their speech pathologist on training and getting set up, and then do their therapy at home, coming in for checkups with their speech pathologist as appropriate. The therapy itself is done typically 3 times a day, 3 days a week, for 8 to 12 weeks. So you can understand how trying to come into a clinician's office to do this therapy 3 times a day, 3 days a week, for 8 to 12 weeks would be very difficult. I mentioned that there's some new data that was not in our application around site of use. We went back and analyzed all of the patients who have used our systems since the inception of our company. It's a little over 1,500 patients. And we found that 86% of those patients were using the device in their home. And this does not include home health. This would be patients using it in an independent manner within their home. Conversely, only 14% are using it in a facility. The facility category would include your skilled nursing facilities, your acute facilities like a hospital. Ultimately, the outcome of this, of course, is to get the patient rehabilitated so that they are, again, able to eat and drink a normal diet as opposed to a modified diet like a feeding tube, while minimizing the risk of getting pneumonia. The device itself, the Swallow Strong system, has 2 components. One component is the Swallow Strong device, and that's what's pictured in the upper right of this slide. We've used a tablet PC as a building block to the device. And I want to emphasize that people sometimes think this is a medical app that runs on the tablet. We use the tablet PC as a building block because it's naturally very portable and naturally very easy to use. We, though, wipe out the software and lock it down, and it can only be used to deliver this very specific therapy of oropharyngeal strengthening, and that's part of our FDA registration. That device directs the patient through an individualized rehabilitation therapy protocol. So it's a very active therapy that's being done between the patient and the device. The device stores all of those results, not just locally, but it also stores it in a cloud-based management system. This is part of our optimization for home use. This allows the administering speech pathologist to be able to check in on the progress of the patient remotely without that patient having to come back in, but ensure that that patient is doing their therapy well, their adherence, results, and see whether any clinical interventions might be needed. The device is portable, as I mentioned, comes in this bag. You can take this pretty much anywhere. I'm happy to show the device to people later. I decided not to spend some of my 15 minutes doing a demo, but would appreciate the opportunity later to actually demo how the product works. At the end of the use by a single patient, which is again going to be about 8 to 12 weeks, they would then return this, it would get cleaned and refurbished, and then be rented out to another patient. The device lasts for about 3 years. And so over the course of its use, we estimate the average device probably gets used by about 25 different patients. The other component of this is the pressure transducer. This is the part of the device that goes in the patient's mouth. The speech pathologist will individually fit this to the specific geometry of the patient's mouth. This will also, it has a chip embedded in it. This is what allows that system that's checked out to many different patients to customize the therapy for the individual patient. Essentially, it allows for the effective use of the device. It is only used by a single patient because of the intimacy of putting it in your mouth, but it will be reused on average anywhere from 70 to 110 times while the patient is doing their therapy. There's some new clinical data that was published in the Journal of the American Geriatric Society in February of this year. This is a study that was funded by, designed by, and run by the VA. So it was not funded by us, looking at the clinical effectiveness of treatment with our device as part of an overall treatment regimen. So I will say that it's part of the overall strategy put together by the responsible speech pathologist. And it found significant improvements both clinically and significant health economic benefits for the healthcare system. For quality of life, there was a validated, standardized, swallowing-specific quality of life tool that was used to look at that. 8 of 11 subscales showed statistically significant improvements, including eating desire, fear, mental health, and fatigue. Similarly, when we say that diets were less restrictive, there's a validated metric called the functional oral intake score that was used there to show how patients had been able to transition safely to a better diet. Arguably, the most significant finding, though, was in the area of the hospital admissions. This study found a 61% decrease, statistically significant, in the rate of hospital admissions for patients who were treated with our products. The authors of the study calculated, based upon the VA's costs, the total amount of money that was saved, and if you divide that by the number of patients, it works out to about $21,000 per patient that was saved in hospitalization cost. And we did provide a copy of this study when we submitted our slides for the meeting. So now I'd like to go through and weigh what I've described in terms of how our product works and is used versus the published criteria for durable medical equipment. So number one, can it withstand repeated use? The Swallow Strong system is used serially by a number of different patients. It gets cleaned and then rented or checked out to the next patient. The pressure transducer accessory is also designed to be reused, in this case, up to 100 or more times by the same patient during the course of their therapy. Number two, is it primarily and customarily used to serve a medical purpose? I've talked about the significance of swallowing disorders as a medical condition. The Swallow Strong device delivers a medical therapy, a rehabilitative therapy to treat this medical condition. And the pressure transducer allows for the effective use of the device. Third, generally is not useful to a person in the absence of an illness or injury. So I mentioned before that the device is designed, even though it does use a tablet PC, no component of the device can be used for any other purpose other than oropharyngeal strengthening. And we can't think of any particularly good reasons to do oropharyngeal strengthening other than to treat the case of swallowing disorders. And finally, is it appropriate for use in the home? And again, we have found that 86% of the patients that have used our devices have used them in exactly that setting. About 60% of the patients who've used our products are within the VA system. And we have a very long history with the VA that accounts for that. Outside of the VA, we have been speaking with a number of different payers, and we've tried to help both our customers and patients as they've attempted to get reimbursement for the product. And the message we consistently hear here is that without a billing code, it is very hard for them to process the claims. So almost invariably, the claims get denied, and it becomes a matter of whether or not the patient has got the stamina to fight that process and try to get reimbursement. We have a number of patients that have paid for this out of their pocket, which means it's become a little bit of a product for those who have the means to do that. whereas we feel with the billing code, it would be easier for these payers to support it. We have also worked with one DME dealer in the Pacific Northwest who stopped carrying our device even though he felt that it fit very well in his business model because of the fact that there wasn't a billing code for it. So to sum it up, dysphagia is a significant issue, has both clinical and economic impacts on the healthcare system, and there's new treatment modalities are needed. We have a treatment modality offered by our product that is effective. The product is reused, it meets the qualifications for DME. Thus, we feel that creating HCPC codes so that it can be billed as DME would be the most appropriate way to treat it. Thank you. Any questions? We don't have any 5-minute speakers. Any questions?
Do you mind going back to the VA study? I
Sure.
have a hard time understanding it. The product is supposed to decrease aspiration pneumonia. And according to this slide, there was really no statistical difference in the pneumonia diagnosis.
Yes. So
how do you account for the decrease in hospital admissions?
So mostly that's an issue of the power of the study. This was actually a cut of the data at the end of fiscal year 14 for the VA. They continued gathering data, and so there's a larger sample size now. The sample size is up over 110, I believe. That particular metric has become statistically significant. I mean, it was not statistically significant at this point with a p-value of 0.1, but it was not that far off. It was just an issue of having a big enough sample size to be able to reach that significance on the pneumonia diagnosis. The other thing that I would like to say from a medical point of view, the device is intended to strengthen the muscles associated with swallowing. And in doing so, you have the end result of less pneumonia and less hospitalization. There are other metrics that were measured that reached statistical significance in the larger sample size, specifically what's called penetration aspiration score, showing that it is clinically effective in its primary goal of decreasing the amount of aspiration.
Thank you. What exactly does the PC device do for the patient? I understand that it directs them through therapy. Is this like, and it stores their regimen as input ostensibly by the speech-language pathologist. Is it like an exercise video?
We wouldn't call it an exercise video because an exercise video to me is more, they show you something and you copy it. What this does, first of all, it holds their individualized protocol in it. So it measures your individual strength on different parts of your tongue using the mouthpiece. Then, based upon the protocol defined by the speech pathologist, it sets a target for pressure with different parts of your tongue. As you push with your tongue on the device that's in your mouth, it indicates that you are or are not reaching your goal and has you do a certain number of repetitions. So everything about your individualized protocol is programmed in there, and it walks the patient through doing all of the steps of that protocol while ensuring and measuring quantitatively that those steps were done. Does that answer the question? I'd be happy if we had time to do a little demo. It makes it a lot easier to understand.
You mentioned there is a system in existence, but you didn't talk about it, right? You just want us to read about it?
The jaw rehab, I think.
The jaw rehab
Yes.
thing?
So it was in our original written application. So the information there, I assume that everyone had access to that, is the jaw rehab device.
Okay.
But we feel that it's a good analogy. It's another oral therapeutic device.
How would the speech therapist get paid then? Would you go and ask for a CPT code?
So there is an existing CPT code today for dysphagia therapy, which encompasses a lot of different things that a speech pathologist may choose to do to treat dysphagia. This device is only one tool that they may use as part of that overall therapy regimen. So regardless of whether they choose to use our tool or not, they'll get reimbursed under that dysphagia treatment CPT code. We feel, because it's a little bit out of sequence between the number of times you see the speech pathologist, do they or do they not choose to use this tool? Is it correct And I mentioned that there's defined criteria that trying to say that it's incorporated into that code would not really line up to one-to-one reimbursement or one-to-one coverage for the use of the tool.
Thank you.
Any other questions? Okay, thank you very much.
So, wait a minute. So isn't that what we would refer to as biofeedback?
So I would say that biofeedback is something where you are specifically measuring a physiological state, and it would be more of a passive state, whereas this is really key in terms of not just providing that monitoring aspect, but also giving the direction to the patient.
But isn't that what the pathologist is billing for? Is biofeedback for dysphagia? Is that the CPT code?
No, it's just dysphagia treatment. So it's not a biofeedback CPT code, it's just a dysphagia treatment CPT code that covers many different things that they could do. The CPT code itself doesn't specifically call out biofeedback. Any other questions? Thank you.
Agenda item number 9, attachments number 16.92 and 93. Repeat and related requests to establish 2 new Level 2 HCPCS codes to identify the components of the Inflow intraurethral valve pump system and activator. Primary speaker is Mr. Terry Moore.
Bear with me a second here. Well, I have to select a... Can you hear me all right on this one? Okay. Come on, help me out here. No, it's coming up on that. Oh, there we go. Okay. Thank you. I apologize. My name is Terry Moore. I'm the Vice President of Sales and Marketing for Vestflow Incorporated, who are the manufacturers and distributors of the Inflow device. And I was actually here last year, shortly after our approval of the device from the FDA in October of 2014. So at that time, we had absolutely no zero usage of the product in a commercial sense because of the fact that we had no funding to build anything until we had approval. So this is really kind of an update to show you where we are and actually to ask once again that you reconsider our application for a code. So I thank you for allowing us to be here today. The Inflow urinary prosthesis for women, it basically addresses a oftentimes overlooked phenomenon among women, and that's underactive bladder. We hear so much about overactive bladder and stress incontinence. This is really for an impaired detrusor contractility. So it actually treats the symptom of chronic urinary retention, where women can't empty their bladders adequately, and as a result have high post-void residuals, which can lead to many different problems. Our application was denied, of course, because of the preliminary fact of the utilization volume was at the time non-existent. Okay, so we would respectfully, ask to have it reconsidered by virtue of the fact that, we don't think it's going to be that huge of a product mix anyway, because of the fact that it is such a defined subset of patients that would be afflicted. okay? But for the women in this situation, their options are very limited presently, and this would provide a very compelling alternative in terms of quality of life and managing things like infections, et cetera, which we'll get into, okay? We therefore ask that the code be reissued to help these patients, and we'll get into that. So basically the device, the Inflow, and just bear with me a second, consists of two parts, really, okay? It's a valve pump mechanism, all right, that is contained within a silastic catheter housing, okay? So basically, this is the device here on its introducer, which you see the syringe-type product there, and then in its deployed configuration, all right? So this device is designed to be inserted once a month, all right? So its indwell time is 29 days, okay? So this would take the place, for example, of 180, 280 straight cats per month, okay, used 4 to 6 times daily, depending on a patient's regimen for emptying her bladder. Or in the case of an indwelling catheter, either a Foley catheter transurethrally or a suprapubic catheter, all right? And basically what that has done then is that there's a valve inside there and a little motor, and it's activated by this handheld rechargeable remote, okay? And for those of you who were here last year, I recognize your faces. We had a different version of this last year, which was the original version of the device from late 97 when we first developed the product, okay? We've since gone to a rechargeable lithium-ion kind of thing to improve the life and performance of the activator itself. But basically what this does is it uses a magnetic field to open the valve in the device, spin it open, and draw urine out. So it actually acts as a prosthetic device in that it replaces the sphincter in terms of a valve mechanism, and more importantly, by creating pressure, negative pressure to pull that out, it compensates for the fact that the detruser can't create pressure itself, okay? What is IDC? IDC is impaired detruser contractility, and it's basically the nerves that innervate the muscles responsible for bladder contraction are somehow impaired, all right? And this can occur based on neurological diseases for the most part, okay? Or a neurological insult like an automobile accident, something that creates pressure on the spine or severs the spinal cord. But then also it's many progressive neurological disease states, multiple sclerosis, Parkinson's, multiple system atrophy, congenital things like cerebral palsy or spina bifida, okay? So for many of these patients, diabetic neuropathy, for many of these patients, this is going to be an incurable and irreparable kind of situation. In the case of someone like a stroke, they may initially have kind of transient inability to empty the bladder, but then that would regenerate over time. But with most of these patients, what we actually see is the symptoms start out mildly and then deteriorate and worsen over time, okay? And that's an important application too when we think about it later on down the road. So it's basically, they're chronic, so it's going to be lifetime catheterization of some mentality. So what we have to understand is the best way to manage those patients for that long term. Their options right now are twofold, really. It's intermittent self-cath, all right, or an indwelling catheter. Okay, again, the Foleys are the suprapubic tubes, which we talked about. So clean intermittent self-cath, performed 4 to 6 times a day, straight cath put in, empty the bladder, or basically an indwelling catheter, and this is vague enough to show that it's either an SP tube or a thing. And again, the thing to point out with both of these that's a little bit different than our device is the fact that these are drained passively, if you will, by gravity. So you're just counting on a straw or a siphon to go in and positionally just drain out, okay? Whereas with our device, okay, it's going to do the following. And I promise this is a video, but it's, oops, sorry, can't find that. It is not gruesome, it is animated. It's Pixar approved. So basically what we have here is a different way of doing things. And it's important that the FDA actually classified the device as a urinary prosthesis. That's not our word, all right? And really, when you think about it, prosthesis compensates for the loss of a normal body function, right? So much like a leg or something else. So it's deployed very simply like so into the patient in dorsal lithotomy. Just goes right in. Okay. The little pedals hold it at the bladder neck, and then it's flush with the meatus outside. Okay. And it basically just sits there like so. It is atraumatic, so that the patient, if they need to, can take it out any time if they were uncomfortable or they lost their activator or something happened. Okay. But what's important here to show is that the activator actually empties that at a rate of about 12 to 14 cc's a second, which is actually urodynamically a very good flow rate for a woman. Okay. What we point out with that is that it actually creates some turbulence in the flow of the urine when it comes out, which, as far as a prosthetic is concerned, we're compensating for normal bladder function, because normal bladder function basically requires three things: periodic, forceful, and complete evacuation of the bladder. Okay? With a gravity drainage, you're not getting that complete and turbulent flow. What happens with most catheters is the fact that it's the urine that is left residual in the bladder is what has most of the sedimentation, and that's where your nidus for infection is going to be found. Okay? So in terms of the aspect of the catheter, so the product has been extensively studied outside the U.S., obviously, because we had our pivotal trial for the FDA, but it was available for a number of years outside the U.S., okay? And basically 1,200 women years of device, and it's been shown to be, absolutely safe. I think the most compelling thing that I could state in the product's favor is that when it did go through the FDA, they actually issued a press release upon the approval of the device. And it is noteworthy that the most significant of adverse events, UTI, appears to occur at a lower rate than the Inflow device as opposed to CIC, which of course is recognized as the gold standard for catheterization. All right? Among patients treated with the Inflow device, UTIs that did occur were stable and easily managed with antibiotics. Okay? And the pivotal trial also showed the Inflow to demonstrate a much better quality of life than the comparable CIC that was the two legs of the study as far as the two arms were concerned. Although CIC is a good option for a lot of patients, there are a whole subset of patients that we've really come to appreciate in our clinical experience this past year that can't or won't do CIC. Okay? And for the most part, it's usually their primary medical condition that makes it almost impossible for them to do intermittent self-cath. The things you need to be able to do self-cath are good manual dexterity, visual acuity, the ability to abduct your legs. Okay? In many cases, patients afflicted in this manner with these neurological conditions, contracted hands, eyesight, all right, and then also the inability to abduct their legs, some of them altogether. With some of these diseases like multiple system atrophy, it's characterized by a lot of contracture of the body, okay? It makes it very difficult for them to do that. So really what we've actually come across is a subset of women who are avoiding catheterization, all right, and their clinicians, and the way they're getting by is basically what we're calling top-off voiding. All right, let's say they can hold 600 cc's in their bladder. They might be able to valsalva or crede and abdominally strain to maybe express 150, 200 of that urine, but the other residual is always there. So the post-void residual is ridiculously high. So as a result, that's where they have the infections that lead not only to UTIs, but urosepsis. And even in some cases, extreme cases, hydronephrosis with fluid building up on the kidneys. I'm obviously preaching to the choir here as far as catheter-associated urinary tract infections. CMS has been very strong in its advocacy of limiting the use of those catheters. Okay, in hospitals for a long time, they were used a little bit too routinely. Okay, and as a result, the UTI rates were up too high. So what we're basically saying is right now we have intermittent caths, which are a great option. All right, but rather than go to the extreme of an indwelling catheter, we'd like to position Inflow as somewhere in between there. Okay. And again, as I said, many of these women can't use intermittent self-cath. And I'm just going to share with you quickly the background of 4 of our patients presently on device, all right? Carolyn is a 74-year-old woman who 20 years after cancer surgery and radiation, her bladder no longer functioned. They had told her that back when she had originally been treated for her cancer, but said that, if I live that long, I'll deal with that then. What she was doing, she was in that class of patient who was just express voiding over the top. At one point, just prior to the month before she went on the Inflow device, she had been hospitalized for urosepsis and hydronephrosis and was actually in the cardiac care unit for 3 days until they realized they had to empty her bladder to be able to do this. That stay alone cost over $45,000. A month later, she went on the Inflow device, and she's remained infection-control since then, okay? Susan A. is a 67-year-old woman with multiple system atrophy. She actually used to complain that she would sit on the toilet. She has 2 caregivers, and they'd say, "Come on, Susan, you have to go." And she's like, "No, I feel like I still have to go." Eventually, she was so problematic with this, they went to a urologist. Because of the difficulty abducting her legs, it took a urologist and 2 nurses 40 minutes to straight cath her and get it successfully in there, and they drained 800 cc's from her bladder. She's now been on device for 3 months and is actually enjoying time out with her family, leaving the house, going out on outings, etc. Because before that, she was just paranoid about a leak at any given time. Jennifer O. is a 41-year-old woman with spina bifida. So she's had to contend with catheterization her entire life. She's actually developmentally challenged too, so lives in a home. But prior to that, she had had a suprapubic tube for a number of years. It's now to the point with the Inflow, and she's been on about 6 months, that she can actually handling all her toileting herself. And she's in a wheelchair, but can transfer to the commode, use Inflow herself successfully, and it's a lot more freedom for her, but also less of a burden on the care staff there. And then finally, Doris C. was actually a picture of the lady earlier sitting outside when I talked about IDC. She's a 94-year-old woman, had a cervical injury to her spine from an automobile accident. It caused her hands to contract in addition to her bladder, so she wasn't able to empty. Basically, what she was doing is she wore a Depends with chucks inside, and she would just basically overflow empty is how she did it, okay? She had actually developed hydronephrosis. She was at the point they were going to have to shunt that kidney, and they put her on Inflow. She's not only completely resolved the hydronephrosis, she's actually no longer wearing Depends or anything else, and she actually said to our nurse when she last saw her last week that she can actually wear real underwear again. So in conclusion, your decision will help determine their options as far as, making this available to them. Bladder drainage with a catheter, bag, and drainage, or being able to sit on a toilet normally, control their own voiding, control their own destiny, if you will.
Thank you.
Thank you. Any questions? Okay, yes, I do. I'm sorry. I have 3.
I'd like to call Laurie Steinbeck, please.
Hello, everybody. My name is Lori, and I would like to thank you for the opportunity to share my experiences with Inflow. I am a patient using the Inflow device, and I have no financial interest in the manufacturer. Due to my MS and the damage it has done to my neurological system, I cannot empty my bladder. For the past 4+ years, I have had to endure intermittent self-catheterization approximately 5 times every day. Making the situation worse is the fact that I cannot do the catheterization myself due to my MS. As such, I have had to depend upon my husband on a 24/7 basis to catheterize me. Up until 4 years ago, before I needed to be catheterized multiple times every day, I had 2 UTIs in my life. During the period during the multiple daily catheterizations, I had approximately 15. Since starting Inflow, I had only 1 UTI. As you might imagine, this illness has taken a terrible toll on me and my family. The only positive thing that has happened to me over the last several years has been Inflow, which I started using in January. Inflow has restored my independence and self-esteem in terms of being able to complete the simple process of urination. On my own, Inflow has significantly improved my quality of life. Thus, I believe that a billing code should be issued for Inflow. Thank you.
Next, we will hear from Steve Steinbeck.
Hi. Thank you for the opportunity to present today. This obviously is a very personal issue, but we feel that despite the embarrassment, it's important that you as decision makers maybe see a firsthand perspective of what's going on. And my perspective is that I'm a caregiver of a patient using the Inflow device, and I also have no financial interest in the product. The Inflow device is life-altering technology, both from a quality of life perspective as well as medical perspective. And let me explain why. From a medical perspective, as you've heard, it's well known that failure to regularly empty your bladder or completely empty it will lead to increased urinary tract infections, kidney damage, and other issues. The Inflow device really shines when you consider how it improves the quality of life. Most people don't think about emptying their bladders other than maybe when you have an urge. And then the only thing on your mind is, where's the toilet? But if you have a neurological problem that prevents natural urination and complete empties the bladder, you have this issue of increased infections, as well as incontinence issues, as have been described by Terry. And furthermore, if you have neurological issues, you may not be able to have the physical manual dexterity to do the catheterizations. And as my wife had mentioned, that basically leaves her either having to go to the doctor daily or having, such as myself, do it whenever it needs to be done. And as you might guess, it kind of consumes your whole life. Your whole life is worried about, how will I get emptied next? Will there be an embarrassment and leakage and everything else going on? So it really is a major issue, and most people would never even think about it unless you have or know someone that has urinary or incontinence issues. Inflow solves both bladder leakage and emptying issues, and it provides as natural possible a solution to being able to urinate and empty completely. As a side note, I would say that when you or a family member is facing an illness or a disease or some kind of issue, you usually have 3 things in mind. One is, what is the solution? Is there a solution? Number 2, who do I go to? What's the best physician or medical practitioner that can help me implement the solution or get well? And then third is, how am I going to afford to pay for it? Okay, and if you're not, one of the 1 or 5 percenters out there, that means that you either have to have the wherewithal to pay for it, or short of that, a billing code so that insurance or Medicare would reimburse for that. And right now, that's going to be a major issue for most people out there, because when it gets submitted to insurance or Medicare, they're going to say, well, there's no billing code, so we can't help you. And I've seen this with a lot of issues because of, with my wife's MS, she takes certain medications which are very expensive, and every time she needs something or needs to have it re-upped, it gets denied routinely, and then it goes back, and finally, most of the time, not always, it gets approved. So the financial interest that we have is making sure that everyone has equal access to a product that can really improve the quality of life, and ultimately, from your perspective, reduce the ultimate cost, because having kidney damage, kidney transplant, all kinds of heavy infections in the UTI tract ultimately costs a great deal more than having the solution that Inflow provides. Thank you.
We will now hear from Rochelle Kachaturian.
I first have to, I'm very impressed that you said my name so well. Ladies and gentlemen of the panel, I thank you in advance for the opportunity to speak with you today about the importance of your reevaluation. Yes, Rochelle Kachaturian. I'm a nurse practitioner with urology in Westmed Medical Group in New York. I'm here to talk to you about reevaluating your initial decision for denying assignment of a HCPCS code for the reimbursement of the Inflow urethral prosthetic device and its placement. There are devices that have established reimbursement codes for men that suffer with urinary retention, and we're asking for the same consideration for women that suffer from the same. I work in a large multi-specialty practice in New York, and I'm here as a provider who sees men and women with many urologic difficulties, but none as life-changing as neurogenic bladder with resulting urinary retention and overflow incontinence. The need to empty your bladder is universal. The inability to do so currently requires one to either wear an indwelling catheter that drains to a leg bag, which as we know can lead to recurrent UTIs and are admittedly not very fashionable, or one would have to be able to self-catheterize, which can also lead to recurrent UTIs due to inconsistent sanitary practices and not always feasible due to dexterity issues or difficult anatomy. I originally saw this product at a SUNA conference last year and was so impressed with the possibilities for my patients that I came home from the conference and told all my female patients who suffer from urinary retention about this amazing technology. My female patients tend to brag about knowing where every bathroom is in Westchester County because they need to know. Every one of them are now excited to be counted in the first wave of patients to be placed on device and brag about not needing to stop at every bathroom they pass. As an NP in urology, the female patients I care for who suffer from neurogenic bladder after experiencing strokes or spinal injury, treatment for pelvic cancers, status post chemo and or radiation, recurrent UTIs that have damaged their bladder's normal functioning, MS, Parkinson's disease, and dementia, all of which can steal a person's freedom, dignity, and their own self-worth. This device can bring back the ability for a woman to see herself in a positive light and improve her quality of life. The human side of this plate is not one you may be aware of unless you or someone you love is afflicted with one of the aforementioned issues. You wouldn't know that the middle-aged woman you're sitting next to on the metro just finished treatment for uterine cancer and is afraid she won't make it to the next stop before her bladder can't hold anymore and she overflows. You wouldn't know that the young mom who has her 3 kids at the park suffers with early MS and has to find a way to self-catheterize when there's often no way of sanitizing her hands while juggling 3 kids in a public restroom. There's also the elderly woman with Parkinson's disease who's afraid to leave her house because her functional incontinence makes her too concerned about not being able to make it to the bathroom in time to be able to enjoy going out in public with her family. I have a 75-year-old patient who's currently on her 3rd month on the Inflow. I'll refer to her as PG. PG had previously seen me 3 times a week for treatment of radiation cystitis suffered after chemo and radiation treatments for rectal cancer, as well as to empty her bladder via catheter at each visit. She suffered with urinary retention, recurrent urinary tract infections, and embarrassing overflow incontinence ever since her cancer treatments ended several years ago. She wore Depends with several pads inside and soaped through them every half hour or so. She was unable to perform CIC because of difficult anatomy due to severe atrophy, secondary to menopause, and radiation. She consistently had over 600 mLs of urine in her bladder after voiding to what she thought was completion. She was the first patient I thought of when I saw the product and the first patient I placed on device. After 2 weeks on Inflow, this is what she wrote to me in an email. Having the Inflow device allows me to feel confident that I'm not soaking a piece of furniture, a car or plane seat, or my clothing. As a single retired woman, staying busy with friends at a movie, play, or simple dinner out are a vital part of my life. I cannot describe to you how the freedom to enjoy these simple aspects of life again have impacted me. The dignity it provides me during my day-to-day activities is simply priceless. I feel like a more complete person with Inflow, and it allows me to live my life to the fullest. I'm at peace. I'm grateful for what I have. Life is a joy. Thank you for all you've done. PG had an appointment with her oncologist today, so she was unable to be here to speak to you directly, but I felt it was important to tell you her story. Please tell me how I can explain to her that the current system will gladly pay for 200 catheters, boxes of gloves, surgical lubricant, and likely a few rounds of antibiotics each month in order to perform CIC, which she, along with many other of my patients, are not able to perform herself. It's also considered acceptable for her to have 12 or more outpatients visit per month to see me to empty her bladder for her in the office, which is costly both monetarily and in time spent. The system will not, however, pay for one Inflow device that does not cost more, requires only one office visit a month, and offers her less incidence of infection and more freedom to enjoy her life. If she were to have to pay for it herself, the cost would be prohibitive. The VesiFlow company has hopes that the successes of patients like mine will encourage CMS to assign a HCPCS code and cover this device in order to help providers like myself help more women regain control over a very personal bodily function.
Thank you.
Thank you very much.
Are there any questions?
So I have a question. Is it Steve? Yes. Thank you. First of all, thank you. Thank you all. And you and your wife. It's a very personal thing to come and provide testimony in a forum like this, and you're very brave. And we appreciate your letting us benefit by your personal experiences here today. Thank you so much. I wanted to ask you if you can tell us if you've had any difficulties having the Inflow device covered or reimbursed to you.
At this point, I can tell you that it's not covered. Well, there are no billing cover codes for it because we had called and they had said there's, unless you can give us a code, it'll be an automatic rejection and then you can go through the appeal process. The only thing that was covered was the insertion. I guess there was a code. Again, I'm not the medical person, but there was a code for, I guess, inserting catheters or emptying patients in the office. But that was the extent of what would be covered. Did that answer your question?
Yes, it does.
Okay.
Thank you very much.
Okay, thanks.
Yeah. And I appreciate everybody's comments as well. I just want to confirm what I've heard here a couple times now. This is always inserted in the physician's office?
No, that's actually a very astute question. The initial insertion is generally performed by a urologist, okay, or a urogynecologist. However, Rochelle, as a nurse practitioner, can also do it herself because she's able to write a prescription. All right, and really the initial one has to be done because I didn't get into the particulars of it, but the variation is in the length of the device from one woman to the next. So basically, they need to be sized so that we know that she's a 3 versus a 5 or a 7, which corresponds to the length. But after the initial placement, subsequent reinsertions can be done either by the patient themselves or, in the case of Lori and Steve, Steve actually does the subsequent reinserts like that. So she doesn't have to go back to the physician's office for that. Some patients are more comfortable. For example, PG's, in her case, she wouldn't be able to do it because she has a very difficult anatomy. It's hard enough for Rochelle to get her, properly positioned in it. But it doesn't necessarily entail a return trip to the physician's office monthly. No? Okay. Thank you very much for your attention.
Agenda item number 10, attachment 16.94, request to establish a new level 2 HCPCS code to identify Walkjoy. Primary speaker is Mr. Blaine Tomlinson.
Am I on here? Am I on now? Okay. Well, first of all, thank you all for letting us come out and share with you our experience with Walkjoy and why we feel it's important to get a code. We're also going to be talking about a neurological disorder. The primary one is peripheral neuropathy. And just recently, we've been approved by FDA for Parkinson's and MS. But the initial device was created for peripheral neuropathy. Joy was my late mother-in-law who had peripheral neuropathy. And our whole mission of the company is to reduce falls in the elderly. And we all know the problem with the wave age. We all know falls are deadly and extremely expensive. This is CDC data about the cost of falls. And what happens with peripheral neuropathy patients, as you all might know, they tend to lose the feeling from about here down. So they become chronic stumblers, fallers, and they can develop major foot ulcers. And so there's approximately 22 to 25 million people in the U.S. with neuropathy. And there's all sorts of major causes, primary being diabetes, chemotherapy, autoimmune. But there's and a lot of the patients we see now are the idiopathic neuropaths are growing, and it's kind of scary. So there is no cure for it. So what we're doing, and like I said, the lower limb amputation is a huge expense as well, because the neuropaths tend, if you've seen them do the PN shuffle, we call it, they spend a lot of time on their metatarsal heads. And what our device does is it helps, they start to have a more normal heel-to-toe rock-off, so it spreads out the dwell time. So those major ulcers are, I wouldn't say eliminated, but it helps reduce it. But initially, what we do, and I'll explain it, is that because they've lost all the sensation in their feet, they've lost proprioception. And so what the device is, basically, if you went back to that Autobach chipset that they had in the IMU, we have the exact same kind of chipset. It's got a microprocessor, it's got a gyro in it, and a triple axis accelerometer. So what we're measuring is the forward movement, the deceleration, and then the lack of gravity. So right upon heel strike, we added 8 linear actuators in here. And they're special actuators. They fire at 30 milliseconds per second. Like the actuators in your cell phone, the rise time on those takes about 80 milliseconds. We need these things to fire as fast as they can, and we're hitting at 250 hertz. So we're targeting the Pacinian corpuscle because it has such a fast rise time to the central nervous system. So these patients know how to walk. They've just lost the sensation of the heel strike. And once the brain gets that signal, or it's told, okay, now your foot just hit the ground, the motor control tends to take over. So there's no calibration involved, such as like walk aid or BioNest for drop foot. So you just turn them on. And then the patient just walks. So right upon heel strike, they get a vibrotactile signal to the central nervous system. And then they start to gradually start walking more normally. And over time, the more they wear them, they get stronger and better. They get a longer stride, they get a faster stride, and their stride time variability, one of the #1 markers for high risk of falls, decreases. So we respectfully disagree that this product is part of a process. Based on FDA, it's a 882-5050 biofeedback device. It's a standalone medical device. Straps on, the patient walks. Unlike walk aid and BioNest for drop foot, you don't have to go in every month and get calibrated and measured all the time. And what we also have inside of it is a software component. So either the physical therapist or the neurologist or whomever, they can see objectively the improvement. We measure stride time variability, we measure velocity, and we measure the range of motion. So they can get a one-page report. They can download the data if they want on their own, but usually the physical therapist or the doctor would check that data. So as I mentioned, drop foot, walk aid, BioNest, and OML, they have the EO770 code for drop foot, for spinal cord. And there's also a code for the electrodes that go with it. And I think they have to replace them every 2 weeks. With WalkJoy, there are no electrodes. It's vibrotactile stimulation. So there's no calibration. There's no continuous going back into the rehab clinic to have it recalibrated. And there's no extra electrodes that have to be purchased. So we've done clinical trials at Willamette University. We had about 34, we call them ice pick neuropaths. You could drive an ice pick through their foot and they wouldn't even know it. About 70%, and we used stride time variability as the #1 marker and velocity. We had a statistically significant decrease in stride time variability from about 30 to 60%. Anything above 20% is considered statistically significant when reducing the stride time variability. And each patient had an increase in velocity and a much longer stride. So the problem right now is that it's the only patients that can afford it. Most of our patients are on a fixed income, 65 and above. And a number of patients have been happy to pay cash, but a lot of our patients can't. So that's why we're requesting either a new code or a modifier against the EO770 to include vibrotactile stimulation for peripheral neuropathy. And that's our main reason for arguing for a code. I've had patients that they're constantly stumbling. They put these on, they walk 20, 50 steps, and they're straight. They're not stumbling, they're more balanced, but they simply can't afford it. So right now, they can use, if they go through a podiatrist or their neurologist and that physician uses GE Care Credit, the patient can finance it interest-free for up to 3 years. But even then, some of these patients can't afford that. We've had patients that have been dependent on their scooters for over 10 years that are now ambulatory. We've got patients that were in wheelchairs that were afraid to walk that are now self-ambulatory. So, and once that happens and they get sedentary, they get fearful of falling, they stop exercising, they stop walking about. And then it's a deteriorating cascade of events. So what we're trying to do, get them up, get them walking, let them feel safe, back in control. And so that's why we're here to hopefully get a code. And I don't know if y'all are familiar with Silverado Care. They're one of the premier senior care living facilities for Alzheimer's and dementia. They put Walkjoy on 10 patients last week. All 10 had a reduction in stride time variability, increase in velocity, and were more stable and in control. And then Health South was using it, before we got FDA approval for Parkinson's, Health South was using it off-label on their Parkinson's patients, and they had the same results. Not on all of them. I mean, even in our clinical study, we had about a 70% statistically efficacy rate. So we don't help every patient, but the ones that we do help, you'll know in 20 to 30 steps. So it's not a long process of trying to figure out whether or not it adds value. So thank you very much. If you have any questions, hopefully I can answer them.
Can you tell us about the data transmission and reporting features, how that happens and who uses the data and for what purpose?
Yeah, I think you've got the Walking Health flyer there, brochure. So when we were developing the software for this, our software guy, because we want it to fire right upon heel strike, so everything that we were measuring, like we were saying, the angle swing, we're measuring this motion and the deceleration. And he said, look, what you're doing is you've got a basic gait analysis tool. So that's when we created Walking Health. And that has a CPT code for doing the gait assessment, gait analysis code. But this device, Walkjoy, captures the exact same data. So if they want to see that data, we can give them a username and a passcode. We don't charge them for that. The flyer you're looking at is a different product, Walking Health. And we're not requesting a code for that. That's what facilities purchase to do gait analysis on the fly. If they don't have Gait Right or Protokinetics or a gait lab, they'll use our device, like in assisted living and independent living. They'll use the Walking Health to see if the resident is a low, medium, or high fall risk. And then if they identify as a high fall risk, then they'll send them either do a balance training class or a strengthening class, and then track their progress. And that Walking Health even measures you can set your G codes, your goals for physical therapy, and you can track it with that device. But those are two separate devices.
Okay, so the data is strictly for use by a practitioner doing the gait evaluation?
For Walking Health, yes.
Okay, and it's getting data from the Walkjoy?
They're two separate devices.
Right, but the device that a
But this
person wears.
Walkjoy does capture that same data.
Okay, so the component of the Walkjoy that's capturing data is really for the benefit of the practitioner in their review?
Yes, if they want to track the patient's objective improvement. They can visually see the improvement, but if they wanted to track their improvement objectively, then we'll give the physical therapist or the physician a username and passcode. Does that make sense? But we wanted the HCPCS code for the Walkjoy device for the patient.
Thank you for the talk, and I apologize. I tried to see if I had a copy of the clinical trial you mentioned, and
yeah, I can email that to you.
Did you have any decrease in the number of falls or amputations in the clinical study?
It wasn't a long enough study, but based on the reduction of stride time variability is one of the #1 indicators for fall risk. So let's say your STV gets up above 10, that resident or that patient is going to go down eventually. So we had some patients in the trial that had like a 14 STV and dropped down to below a 6. But there weren't any falls in the trial, if that's what you're asking. But the trial only took 2 weeks. But we haven't done a longitudinal study to show, okay, this patient was a chronic faller, and they've had the device on for a year. or 2 years, and they haven't fallen in that period. We do have anecdotal evidence to that. We had one patient down in South Carolina. He was a rancher, 82, diabetic, peripheral neuropathy, but you couldn't stop him from walking his fence every day. And he would go down every other day or every 3 days, he'd fall. But he was in the dirt and on the grass, so he never really injured himself. But he started wearing Walkjoy and had it warm for about 14 months, and he never fell one time while he had him. And then sadly enough, he had a stroke and he's no longer with us, but that is one of the long-term anecdotal cases. But we haven't done a longitudinal study, which we are going to do. We're working with the UCSD neurological clinic out of Colorado, and one in Long Island, to start collecting that longitudinal data. But our mission statement is to catch them before they fall. Our whole mission of the company is to reduce falls in the elderly. So, is that it? It's kind of cold in here, so my... Oops. I don't want to go home with this.
We wouldn't let you.
Yeah, thank you.
Thanks. Okay. Agenda item number 11, attachment 16.95, request to establish a new level 2 HCPCS code to identify tailwind. There are no speakers for this item. Are there any questions or comments? Agenda item number 12, attachment 16.8 and 16.72, two separate but related requests to establish a total of 5 new level 2 HCPCS drug codes to identify polymerized cross-link sucralfate products, including prothelial mucositis paste in 2 sizes and oralfate oral anti-inflammation paste in 3 sizes. There are no speakers for this item. Are there any questions or comments? Okay, that brings this meeting to a close. We would like to thank all of you for coming out and for all of your excellent and thought-provoking discussion, and for taking time out of your busy schedules to appear here in person at CMS. We'd like to thank you again for all your valuable input. Have a wonderful day, and we look forward to seeing you maybe next year. You're welcome.